Off and running with Chapter 12, shock. What exactly is shock? Well, shock is, in medical terminology, hypoperfusion. So hypoperfusion is low or inadequate supply of oxygenated blood to the tissues. At the end of the day, when all is said and done, if our tissues and our cells continue to receive an oxygenated blood supply, they're going to go on like happy campers, create all the energy that they need to. It's going to produce a very small amount of waste product, and our body is going to function at its optimal. When it's under duress and things aren't going the way that they're supposed to, we switch from that aerobic metabolism, which is energy creation in the presence of oxygen and glucose, to that anaerobic metabolism we talked about in Chapter 6, which is energy creation without the presence of oxygen and glucose. It's much less efficient, it creates way more waste products, and those waste products at the end of the day are what causes those cells, those tissues, those organ systems, and that organism to begin to fail. Luckily for us, there are some check boxes along the way where we can figure all this out, even if we don't know for sure what the problem is, and realize, hey, sick person right here in front of me, I better be on about my business. Shock is when the perfusion does not meet the needs of the cell, period. Without that glucose and without that oxygen, the cells of the body, with one very specific exception, will switch to anaerobic metabolism and still create energy. That one exception is the cells of the brain. The brain does not switch to anaerobic metabolism. The brain will no longer continue to create energy if an adequate supply of oxygen and glucose isn't being delivered to it. If those cells in the brain aren't getting their oxygen, aren't getting their glucose, and won't create energy, what's one of the logical things that you think starts to happen with a patient who's in shock?
They start to actually like get dizzy and start to see stuff.
So sure, on a breakdown level, I'll take that. What we're really looking for is even the
Circulation.
slightest alteration in your patient's mental status in the presence of something you think could have sent them into shock is a significant finding. It doesn't have to be this giant, all-encompassing, hey, this is really, really bad moment for you. Because there's no actual test for shock. They don't draw labs and do x-rays and do this and do that. No, there's no real clinical bit of diagnosis for this. We match signs and symptoms with injury pattern or with illness pattern, and we come up with, hey, it's pretty likely that these things have caused my patient some state of hypoperfusion. And we treat that aggressively because when left uncorrected, shock will lead to death. Question?
My question was, isn't shock our body's response to like that fight or flight? So like when we have a trauma, we got a big cut, like our body turns to shock. So, what's the word that I'm looking for? So like when we're bleeding out, it'll help us not bleed out as fast.
So you're in the right neighborhood, you're just at the wrong house.
Okay.
That fight or flight response is your body's natural response to being hypoperfused. And we'll get into that a little bit deeper into this lecture. So hold on to that question because it'll all come together in just a few, but you're close. So we talked about the oxygen and delivery. We talked about the impairment of energy creation with that anaerobic metabolism. We've mentioned that all of those waste products are going to begin to accumulate, and sooner or later, all of those waste products, when the sodium-potassium pump fails, get pumped into the cell. The cell will lyse, which is a fancy $10 word for explode, and eventually that cell dies. And that's happening to all the cells in this area that is not receiving adequate perfusion. That's happening to the tissues that are made from those cells. That's happening to the organs that are made from those tissues. And right on down the line it goes until the body just marches its way right on down to no longer being the metabolic machine that it needs to be, and our patient expires. What is a cell? Well, a cell is the basic unit of life. We are made up of an unbelievable number of these. I quite honestly haven't done the math. I'm sure it's out there on the Google somewhere, but I'm not going to do it because that number must be huge. These are microscopic little things that make up every bit of us. In order to stay alive and continue on with their job, because every cell, every tissue, every organ has a job to do, they need that oxygen, they need the glucose to form the adenosine triphosphate and create the energy to carry out what their job is, what their specific function in life is. No oxygen, no energy, no life, period. So this all sounds pretty significant, yeah?
Yes.
Okay,
Yes.
good. Somebody's out there. Now, let's get into the wheres and what fors, because you hear me blabber on and on and on and on about how this whole thing boils down to pumps, pipes, or fluid, right? I've probably said that 100 times in the last week. Well, here we
Yes.
go. Perfusion failure. So a patient who's going to go into shock or is currently already in shock boils down to one of these three problems. We either have a pump failure and the heart is not functioning appropriately at its job as being a pump. We have a pipe problem and the vessels either get too big or begin to leak. Or we have a volume problem. Now, the volume problem we saw pretty easily depicted with the guy in chapter 6 who lost a fight with an angle grinder and was pouring his perfusing blood volume all over the floor. That's pretty simple to figure out. Loss of blood volume, whether it is whole blood pouring out from a wound or blood plasma from something like a non-hemorrhagic cause like nausea, vomiting, diarrhea for an extended period of time, or significant burns just allowing our plasma to evaporate away, is going to cause a loss of volume. If we can't fill our pipes, our pump can't function, perfusion goes away. Perfusion goes away, we wind up hypoperfused. That hypoperfused state forces our cells to switch over to anaerobic metabolism from aerobic metabolism, and the beat goes on. Right down the line we go into shock. And then the sodium potassium pump fails when all that acidic waste builds up. And that acidic waste goes into the cell. Cell says, I'm not doing this. Off it goes. And here we go again. Cells die, tissues die, organ system die. And then your patient, the metabolic organism that they are, says, you know what? I'm not doing this anymore either. And then they die. And these are the root cause of all of this. It's either the pump not meeting its job as it's either the heart not meeting its job as a pump, the pipe not carrying out their job to maintain pressure and keep blood moving around, or we don't have enough to fill the tank anymore. That's where we wind up. Some of this respiratory pathophys should look familiar, I hope. This is going over that whole gas exchange process. I put a handout up on Tavuti that shows, you know, how gas moves from high concentration to low concentration. We have a high concentration of oxygen in these alveoli here on the left-hand side. We have a low concentration of carbon dioxide. The blood that comes from the right side of the heart, since it's already delivered its oxygen and picked up a whole bunch of carbon dioxide, which is one of the main waste products of aerobic metabolism. The blood that comes from that right ventricle has a low concentration of oxygen, has a high concentration of carbon dioxide, and those gases diffuse into and out of the alveoli respectively, and headed back to the left side of the heart here, we have this red, freshly oxygenated blood getting ready to be pumped out to the entire body from the left ventricle, and round this goes. When it stops, nobody knows. When we look at the right side of this picture, we have our freshly oxygenated oxyhemoglobin here out near the cells and the tissues. That oxyhemoglobin has a high concentration of O2 and a low concentration of CO2. But those cells have already produced energy. They've already used the oxygen that was dropped off to them before. So they've created CO2. This blood right here, the oxyhemoglobin, has a very low concentration of carbon dioxide. So as we move along down, this oxyhemoglobin gets near an oxygen poor cell, and that oxygen diffuses out of our oxyhemoglobin, off of our red blood cells, and into the cells and the tissues so that more energy can be created. Since we have a very low concentration CO2 right here and a high concentration CO2 right here, the CO2 diffuses into our bloodstream, goes right back through systemic circulation to the right side of the heart, and the right side of the heart pumps it to the lungs, so we breathe out all that CO2. Oxygen goes back into the bloodstream, onto those hemoglobin, and round this goes. That's one drop of blood through the entire heart and circulatory system ad nauseum. This just continues to click away every heartbeat of every minute of your entire life. Are there any questions yet?
Mm. That's a lot.
It is
For
a lot.
every
The key points on this to remember are alveoli, high
alveoli.
concentration of oxygen, low concentration of CO2. Cells are just the opposite. They have a high concentration of CO2 because they've already created their energy and made their waste products. But they have a low concentration of oxygen because they've already used it. So those gases move from high concentration to low concentration respectively, depending on what they're near. So if we have a lot of this right here, we have a lot of oxygen in those alveoli, and we want that oxygen out of the alveoli and into the blood. That means we have a little oxygen here, because to create that oxygenated, that oxyhemoglobin, that oxygen has to get out of those alveoli. So that capillary blood that surrounds the alveoli has a low concentration. That's how those gases are going to wind up moving. If we look at the reverse of it, what do we have inside the alveoli for this? Is it a high concentration or a low concentration?
Low.
Low.
High.
No, you were right the first time. Don't second guess yourself.
Low.
See?
Yeah, it's a low concentration of CO2 in the alveoli. But what's the concentration here?
See, to me, blue looks like oxygen.
No, they always depict blue as no oxygen, and they depict the red as oxygenated.
Oh, wow.
Even if I made this black and white, though,
Yeah.
if we have a low concentration of CO2 in the alveoli, because you were right, and we want CO2 to go into the alveoli so that we can breathe it away, this blood that's returning, this is coming back from the body, this blue blood right here. So what's it going to have a lot of?
CO2.
Yeah.
Absolutely. Because that's the only way those gases are actually going to pass by each other and get breathed out of our human. Because if they were even, we would never get anything to move. or if we had a low concentration of CO2 here and a low concentration of CO2 here, or a high concentration of CO2 here, the gases would go the wrong direction. CO2 is a waste product. CO2 is what we're trying to get rid of. So when that comes back from the body and winds up in those capillary beds that are near those alveoli, CO2 is what we breathe out. Carbon dioxide is what goes away. So it needs to get from that blood, from that deoxygenated hemoglobin, and out of our human. And it happens just based on how much is where. So this is probably important, right? Because we're only 8 slides in, and this is the second time we've seen this. And shock does not need to be hugely confusing. We do have to grind our way through figuring out the way these gases move and the whys that these gases move. And some of our respiratory lecture tomorrow is based a little bit on that as well. But at the end of the day, either the pump's not working, the pipes aren't working, or the fluid is in too small of a volume. And all of it circles right back to we are unable to remain and keep enough pressure to perfuse our human. That's it. That's the crux of all of this. If the pipes aren't working, the pump isn't working, or there isn't enough fluid, we wind up not having enough pressure. That's why we measure blood pressure so often and so appropriately on our patients, because all of this is driven by pressure. You know, when we did chapter 6, and I sort of referred to in your house, right? If you don't have enough water pressure, the water's not going to go anywhere. You're going to get a crummy shower. The same thing happens in our body. If we don't have enough blood pressure, we're not going to perfuse all of our tissues, and we're going to have a crummy outcome. So there's a bunch of ways that all this stuff can happen. We can have anything and everything that damages the heart's ability to pump. So think of things that we may have already talked about a little bit. Do you think a heart attack where entire pieces of the muscle that is supposed to be maintaining a pressure and pumping this blood supply around that now have died from a myocardial infarction would interfere with the heart's ability to function as a pump?
Yes.
Yes. All right. When we talked about pharmacology yesterday, we mentioned anaphylaxis and how we're going to give epinephrine in an effort to constrict down our patient's vascular system and make their blood pressure go up. Anaphylaxis is a problem where the blood vessels dilate too rapidly. On top of dilating too rapidly, they become leaky. So now we have a container, we have pipes that are 2, maybe 3 sizes too big for the amount of blood we have available. Does that sound like we'd have a problem maintaining the pressure and getting a good shower?
Yeah.
That's exactly what happens in anaphylaxis, and that's exactly why we give epinephrine to fix it. Because
So
now we have a pipe problem. And if we make those pipes the size they're supposed to be again, we no longer have a pressure problem. We no longer have a perfusion problem.
So shock
Jessica,
goes
do you have a
along.
question? Was there a question out there?
I was just saying to myself, it seems like shock goes along with everything.
I'm really happy that you said that. Want to know why?
Why?
Because it does.
Okay.
So we are a metabolic machine. Anything that
Yeah.
interferes with that ability to metabolize and create energy, shock runs right along hand in hand with it. And you know how they say, oh, the patient died of a cardiac arrest. Yeah, sure. The patient's heart stopped pumping. They stopped breathing. Cardiac arrest is what began this whole process. But you want to know what everybody really dies from?
The body going into shock and the lack of everything pumping and being a lot.
Once all that pumping and once all that breathing and all that oxygenation and ventilation and respiration stop, the patient starts going into shock. And this tissue perfusion and cellular perfusion going away is really what kills somebody when they go into cardiac arrest. When we do CPR or station 1 cardiac arrest management on a patient, we are trying to stave off a little bit these negative consequences from hypoperfusion by circulating blood and oxygenating our patient with a BVM.
So
And
Tommy,
all we're really doing is fighting shock.
my
Go ahead.
fault. I was gonna say, is it true that when people go into shock, sometimes their body like has that little herky jerky motion?
Yeah, we're going to get into some of the body's response to it here in just a couple minutes. And it
All
seems
right,
like,
cool. I'll hold my fault back. My fault.
no, don't worry about it. I'm glad to have questions. It seems like at the moment, though, so far so good. So we've talked about the pump problem. We've talked about the pipe problem. Now let's talk about the fluid problem. Now, the easy one for this is hemorrhagic hypovolemic shock. So hemorrhagic means there's a bleed. Hypo is low, volemic, volume of blood. That's simple. We have an open artery spraying blood all over the room, painting the walls, painting the ceiling, painting the floor. Well, all of that blood was supposed to be on the inside, helping to maintain pressure, delivering perfusion and removing the products of cellular metabolism. If I'm spraying it all over this room here, is it doing any of that?
Oh, no.
No, we have a volume problem because my volume is winding up on the walls. Let's look at some of the little bit trickier piece of that now. Let's say we have a patient who's really sick and they've had nausea, vomiting, and diarrhea for 4, 5, 6 days, haven't been able to hold anything down. We've all heard of dehydration before, right? That dehydration is really a loss of that salty water, that plasma that makes up more than half of our circulating blood volume. So our blood no longer is watery like it's supposed to be. And if we don't have the ability to replace or maintain that volume, we don't have the ability to move oxygen here and there. We don't have the ability to maintain a pressure, and we don't have the ability to perfuse our person. It doesn't matter what the cause really is. Once we look at, is it a pump problem? Is it a pipe problem? Is it a fluid problem? We can actually, realistically, see these things, fix these things, and see a patient get better. Epinephrine and anaphylaxis are two of probably like the biggest depictions of that. You can take a patient who is in severe anaphylactic shock, trying very hard to die right in front of you, and in under 15 seconds, completely reverse all of those things with one IM injection. And from the end of that 15 seconds until you deliver them to the emergency room, you will watch their condition improve. You will see that their blood pressure sort of returns to a more normal, more reasonable level. You will see their mentation start to get better. You will see their oxygenation and ventilation and respiration actually physically improving right there in front of you. And really where we earn our money when we talk about hypoperfusion is recognition. Recognizing the fact that our patient has been involved in something that is likely to cause a series of events that will lead this patient into shock and responding accordingly. Now, for the most part, the treatment for shock is very, very easy. Does this sound like it's an oxygenation problem?
No, it can't
No.
be.
It can't be or can be?
It cannot.
Why not?
Well, I think it can be in a pulmonary sense. If we're having respiratory distress, then yeah, that's a form of shock because our body is trying to compensate for the air that we can't breathe.
All
So
right,
we're going to give oxygen.
I want to take this one step a little bit further, and then I'll ask the question again. When the heart is pumping, what is it pumping around?
The blood.
All right, and what is that blood carrying?
Oh,
Hang on, I'm
oxygen.
gonna keep going. Don't stop now. What is that blood carrying?
Oxygen.
All right. And when it's being pumped through those blood vessels, what are those blood vessels carrying?
Carbon monoxide. CO2.
Or
Or oxygen.
Or
oxygen.
oxygen.
And that blood,
Delivering it to the
yes,
body.
delivering it to those cells or bringing it back to the lungs so we breathe away that CO2. So what is one of the main functions of that blood that's being pumped around by that heart through those vessels?
To grab oxygen and deliver it somewhere else.
You got it. So let me ask it again. Do we think that shock eventually whittles its way down to an oxygenation problem?
Yeah,
Yes.
the simplest form it is the oxygen problem.
Yeah, so one of our treatments when we think a patient is in shock is to place a non-rebreather mask set at 15 liters per minute on their face. The minute we think they're going to be in shock, they get oxygen. Because even if oxygen delivery and oxygenation of the cells and tissues isn't a problem right now, guess what? It's gonna be. So we get out in front of it because shock doesn't get better on its own. So oxygenation and ensuring proper ventilation. So now we need to make sure that they have that adequate chest rise and fall, and their airway and their breathing and their circulation are functioning appropriately. So we oxygenate our patient or we ventilate our patient. Another thing that we need to do is make sure that we lay them flat. We don't want their heart having to pump against gravity, because if the heart has to struggle, it's going to require more energy. And if it requires more energy, it's going to require more oxygen and glucose. And oxygen and glucose are already a problem. So is needing more of it a good idea? No. So
No.
we take a patient we think is in shock and we lay them out flat. And the last little bit of your standard shock treatment is we want to keep these people warm. That sounds odd, don't you think? Why does keeping them warm make a lick of difference?
Because we're clearly using up all our energy, so we're not going to temperature our body right.
Perfect. I am so happy you said that. You're absolutely right. When our body is cold, what does it do?
It shivers.
Close up.
Yeah, and shivering is actually constant and continuous muscle contraction in an effort to try and generate heat. So if those muscles are contracting and relaxing, contracting and relaxing, contracting and relaxing, contracting and relaxing, what are they going to want a lot of?
Heat.
Heat. They're trying to make heat, but they're going to want a lot of blood, and they're going to want a lot of oxygen, and they're going to want a lot of sugar because they are blowing through energy like it's free. So if we know that oxygenation and cellular metabolism are a problem, we can make our peace with that. We want to keep these people warm, we want to lay them flat, and we want to ensure that they are ventilating and oxygenating appropriately, because anything that requires more oxygen, more sugar, more blood flow is going to cause more negative reaction from the body when it's in a state of shock. That's just the way these dominoes start to fall, because some of the body's reaction and normal compensatory mechanisms, which we'll see here in just a couple minutes, already amp up the oxygen demand. So we need to give more. They already amp up the body's efforts to try and get gas in and get more gas in and get more oxygen in and get more oxygenated blood circled round and round and round we go. So the body physically, in order to try and keep itself alive, already ramps up its own O2 demand. So we can't have our patient shivering and having these muscles that amount to a hill of nothing if the patient dies from hypoperfusion, continuing to contract and try and generate heat. So we oxygenate, ventilate if need be, lay them down, and keep them warm. I want to ask one more question, and then we're going to move on. When during your patient assessment do you think we find a lot of these problems?
In the beginning.
Feeling general
Ideally, you
impression.
want to say that you would find them initially, but most people just don't. They're always there. The issues are there. People just don't necessarily pay attention to them.
Okay, I heard initially, that makes me happy. I heard early, that also makes me happy.
The general
So
impression.
far we've gone on and looked at our scene size up, our primary assessment, and yesterday you guys all got introduced to your secondary assessment of a medical patient. So out of those three things, ideally, when do you find this?
The primary assessment.
The
The
primary
general
assessment,
impression.
general impression, absolutely. The very, very beginning of our primary assessment is our general impression, level of consciousness, airway, breathing, circulation.
Okay.
We're going to see these actual physical problems during our primary assessment. When do you think we should fix them?
First.
Yeah, first, you find a primary problem during your primary assessment. Get on about the business of getting this wrapped up and tidied up and fixed. So that's why we provide oxygen during
Yeah.
breathing. That's why we check skin color, temperature, and condition. That's why we evaluate our patient's pulse, because these are the things, these are the times where we're going to find and make the biggest difference in a patient who's in shock. And it's that simple. We have connected all the dots during our general impression, level of consciousness, airway, breathing, circulation, and we can start affecting a difference in our patient and beginning to make them at least not get any worse within the first 90 seconds of laying eyes on this patient. It's like throwing a light switch. You look at somebody and you say, all right, well, I'm here because they lost an argument with a chainsaw, and a lot of their circulating blood volume is on the ground. I can see it surrounding the patient as I approach. I'm forming my general impression. This patient looks like they have an open artery spraying blood at me as I'm walking towards them. They're conscious and alert and speaking to me, so I know they have a patent airway. They're breathing. Do you think they're probably going to be breathing pretty quick?
Yes.
Why do
They're
you
going
think?
in.
Yeah, because they're going into shock. So their respiratory rate is going to go up because the body is attempting to bring more oxygen in. So their respiratory rate goes up because the body realizes that oxygenation and perfusion is going to be an issue. So I've measured now their breathing, their rate, rhythm, and quality. It's probably crap. So I put oxygen on them, 15 liters per minute, non-rebreather mask.
Control the bleed and get out of there.
Control the bleed. I'm going to get to that because I was just about to kill this guy and I wanted to go back to it. So control the bleed. I'm going to put you on the spot there, Miss Montalvo.
Oh man.
You mentioned controlling the bleed. When do you think I should have done that?
Well, I think we should have.
When you first got there.
When I first got there. Why?
Because you want to control the perfusion of the body.
Yeah, I need that leak to
You're gonna
stop.
lose so much blood.
The leak is the problem. The patient's only got so much before they're going to be on E. So when we find a significant bleed in the field, that is the absolute most immediate life threat we will ever come across. Because I can tell you, it takes anywhere from 60 to 90 seconds for someone who has got an uncontrolled significant hemorrhage to bleed to death. Sometimes even less than a minute. How long do you think it takes to approach your patient, form your general impression, get their level of consciousness, assess and treat airway problems, assess and treat breathing problems, assess and treat circulatory problems?
The first 5 minutes.
So if it only takes sometimes under a minute to bleed to death, and we're going to say it takes 5 minutes to perform actual appropriate primary assessment, We're -4 on the minute clock, and my patient's been dead for 4.5 minutes.
I would say within the seconds. Within, as soon as we walk in.
You are going to evaluate your patients for gross hemorrhage as you're forming your general impression. That's going to be something you should look for. That should be in your mind as a trigger. As I'm approaching my patient, I'm looking for any signs of gross hemorrhage. Because it takes 60 to 90 seconds to bleed to death. And it probably takes the same amount of time, realistically, once you get good at it, to perform an adequate primary assessment. So one way or the other, this patient has still bled to death. So gross hemorrhage, a volume problem, is going to be corrected first and foremost. If you find severe bleeding, you fix severe bleeding, because otherwise everything else goes for nothing.
Yeah.
Seems to me like you all are reading the textbook. That makes me happy. So I'm going to show you guys a
I'm
picture.
not trying to fail.
What's that?
I said I'm trying not to fail.
Well, keep trying, because right now everything looks good as far as I'm concerned. Here is a picture. I think we've made our peace with a leak problem with blood pouring all over the floor. But now here's inadequate vessel tone. Now I talked about anaphylaxis, and this legitimately is the physiology of what happens inside of our patient when anaphylaxis happens. They get introduced to something that stimulates this reaction, and this reaction causes all of the vasculature to get huge and dilate. And we only have enough blood to fill this much space. But now we have this much space. You ever remember being a kid and going to like the Museum of Science, and they have that wave room, right? Where they have this arm that pushes the water and you watch the waves go across the room? That's exactly what happens here with this inadequate vessel tone. There's not enough blood to maintain a blood pressure. So sure, the heart's going to keep pumping, the heart's going to keep contracting, but all that's going to happen is a little bit of wave and a little bit of nothing, because that blood's not going anywhere because there's no pressure built up in the system. When we give our epinephrine and we treat our anaphylaxis patient appropriately, we wind up back over here. And now we have enough blood to fill the tank because the tank is the appropriate size. And if the tank is the appropriate size, we have a decent pressure. And if we have a decent pressure, guess what? We have fixed the state of hypoperfusion that our patient was exposed to. And that is right then when you're going to actually witness your patient get better. Epinephrine is a naturally occurring catecholamine. It is a naturally occurring substance in your body that your body produces. Epinephrine stimulates the sympathetic nervous system. Guess what your body's initial response to shock is in the first place?
Adrenaline.
Adrenaline, that fight or flight reaction. Want to know what the main chemical in that fight or flight response is?
Epinephrine.
Epinephrine. So when a patient is exposed to shock, the first thing that the body does is clamp down the vasculature as much as it can because it's trying to maintain a pressure. One of the next things the body does, these all things pretty much happen simultaneously. The body dumps an obscene amount of epinephrine into the bloodstream, and the vasculature constricts down. Epinephrine makes the heart rate go up. Epinephrine makes the respiratory rate go up. And as these things are happening, my respiratory rate gets faster because I'm trying to bring more oxygen in. My heart rate gets faster because I'm trying to bring more oxygen in and pump that oxygenated blood around quicker. The vascular structure shrinks down to actually make my blood pressure go up maybe a little bit initially. And maybe it closes off some of those little micro vessels to places that aren't important. Because in an effort to combat shock, the body will write off just about everything that isn't heart, lung, or brains. It will say, the hell with everything else. We need to keep these three organs functioning while we sort out the rest of this business. So that's why your patient may start to have some nausea, some vomiting. But let's talk about epinephrine here for another second. Now, Nathaniel, I think you asked about patient being kind of like jerky and twitchy and, you know, acting a little funny.
Yeah, yeah.
All right. What normally happens when, you know, you're placed in a situation where your body's fight or flight response is stimulated? Does your brain normally really process information altogether that great?
No, not really. Because don't you start to like think like out of sorts and like you hyperventilate and you just go into a whole like frenzy.
Yeah, exactly. You get kind of jittery, you get kind of twitchy. You're not going to be doing any, you know, any high level math problems. You are capable of processing nothing but simple information at that point. When your body is, the sympathetic nervous system is stimulated and that adrenaline is coursing around you, you are really just a stay alive machine at that point. That is what the body is concentrating on doing.
So
And
isn't that why they usually tell people like, hey, do you remember what day it is? Like, when's your birthday and stuff like that? While they're actually trying to help.
that's absolutely part of why we ask simple questions for our level of consciousness check. Because when placed under stress, your patient's not going to remember the difficult things, but they should remember the easy stuff. And shock is no different. When the body senses that they have a problem, whether it's pump, whether it's pipe, whether it's fluid, doesn't matter at this point. It will soon, but it doesn't right this second. It releases all that epinephrine. And from that very given point forward, the only mission of your body is to stay alive as long as possible until something, someone, or some object comes along and fixes this issue. Because without being addressed and without being corrected, shock always leads to dead patient. There's no other option. So we're going to go through this next slide here, and we're going to take a couple minutes to get up and move around and just take a break, because as long as we can get this sort of buttoned up and nailed down, I don't care what else we get done today, because chapter 14 can be done in person because it's all about patient assessment anyhow. But let's have a look here. Shock comes in a couple of different flavors. So in the middle of this picture here, we have shock. And we've already, I think, gotten the hypovolemic portion of it pretty well nailed down. It's either hemorrhagic or it's not hemorrhagic. If it's hemorrhagic, that means my patient has sprung a leak and their circulating blood volume is all over the walls. If it's non-hemorrhagic, it's going to be from something like a burn or something that causes your patient prolonged periods of dehydration. So think prolonged nausea, vomiting, diarrhea, patients who are unable to hold down any fluids, or even, no, let's just stop there. So think things like a burn patient who's got an inability to maintain their blood plasma, or someone who is just malnourished. Cardiogenic shock, that's our pump. Our pump, for one reason or another, isn't working. Now, it could be from a heart attack. It could be some form of abnormal heart rhythm that is making the heart now not pump effectively. But our cardiogenic shock is really just the heart is no longer meeting the body's needs as a pump. It's just not doing it effectively. We're going to skip metabolic and respiratory here for a minute. And now we're going to go across the way to distributive shock. So with our distributive shock, blood is not being distributed appropriately. Blood is not distributed appropriately because there's a tank problem. The pipes are no good. Jessica, do you have a question?
No. I was thinking while you were going over shock, I was thinking when you said about the body ultimately dies of shock. In my head, I was going back to something and I said septic shock. That means that ultimately our blood was poisoned and it died of septic shock. So I seen septic and I said to myself, oh, there's the septic.
You got it. So distributive shock means there's a vessel problem. There's a pipe issue. The vessels, for one reason or another, have gotten too big. We don't have enough volume to fill it. So without having enough volume to fill it, we can't maintain a pressure. If we can't maintain a pressure, blood's not getting moved, and we circle right back to cells, tissues, organs, and organ systems aren't being adequately perfused. So anaphylactic, we already went over. We covered that. Septic shock, you're absolutely right. The body's blood has had some sort of bacteria introduced to it. So one of the things we look for with septic shock is a known source of infection. UTIs and pneumonia in the elderly people are absolute nightmares for causing septic shock. So we have some form of infection, right? And for one reason or another, the body isn't able to combat that. The medication isn't working, and our patient gets sicker. And soon enough, all that bacteria really gets into the bloodstream in high concentrations, and it gets pumped out throughout the entire system. It becomes a systemic problem. And that high level of bacteria in our patient's blood causes wide-scale vasodilation, and it causes the vascular structure to actually now begin to leak. So with septic shock, our blood vessels just got too big, and we don't have enough blood to fill them. And on top of being too big and not having enough blood to fill them, they leak. So now we have blood distributed to the far reaches of the body. We don't have enough pressure to get any of it back, and we wind up hypoperfused again. Oxygen's not being delivered, carbon dioxide's not being removed, and at the end of the day, all those cells and all those tissues are going to switch from aerobic to anaerobic metabolism, and then the dominoes start falling, and one after another they just tip over. Now, neurogenic shock is a horse of a different feather altogether. So vascular tone, do you remember what I told you it was controlled by? Which part of the nervous system?
That one I don't remember.
All right. Vascular tone is controlled by the sympathetic nervous system. That's epinephrine all day, every day.
Okay.
In neurogenic shock, our patient has received some sort of spinal cord injury. And below the level of that spinal cord injury, the body's not getting any messages from the brain. So none of that epinephrine is being released to control the smooth muscle that surrounds all that vasculature. And if epinephrine's not getting down there, the blood vessels won't expand and contract the way they're supposed to. They just expand. So below the level of wherever that patient has received their spinal cord injury, we're going to have humongous amounts of vasodilation. So we're going to have vasodilation below wherever that spinal cord was injured, and a lack of systemic vascular pressure, which means we don't have enough pressure to run the system, which means blood's not going round and round like it's supposed to, which means oxygen not getting delivered like it's supposed to, carbon dioxide not getting removed like it's supposed to, and these tissues below the injury of the spinal cord, since the brain's no longer talking to them, wind up being hypoperfused and switching to anaerobic metabolism. And then we're right back to cells die, tissues die, organ systems die. And sooner rather than later, yet again, our poor patient, who now not only has a spinal cord injury, also has neurogenic shock and is in cardiac arrest. Whoops.
Wow. When we say spinal, I'm sorry. Would that count as the cervical spine as well?
It would. The cervical spine normally winds up with its own sort of, um,
Because I know that, we got a whole C-spine in a trauma, so I was just thinking ahead of myself. My bad.
no, that's not really a head. I'm trying to figure out how to answer your question without being more confusing.
No,
Um,
that
our C-spine houses even more important structures than the rest of the spinal cord.
okay.
This, when we talk neurogenic shock, is normally limited to maybe a little bit further down.
Like pelvis, lumbar.
Even in like the middle of the spine, like the thoracic spine, um, it's
Like
just all of the important, like the respiratory centers, what controls your heart rate, what controls your heart beating, is all controlled high up in the cervical spine. Normally, when we see problems up that high, we see a whole lot bigger problems than just neurogenic shock.
Okay.
So let's move down one here to obstructive shock. So all of this is predicated on the body being able to move blood around and oxygen and glucose being delivered, carbon dioxide and other waste products being removed. What happens if there's a pretty significant obstruction along the way somewhere? And I don't mean obstruction necessarily like, you know, like choking or anything like that. I mean obstruction in this whole circulatory part.
Like a clot or an air bubble in the lung.
Could be a clot, could be blood can't get back to the heart, it could be blood can't get pumped out by the heart. Something is causing a traffic jam. Whether it's a tension pneumothorax, which is a buildup of pressure in our interthoracic space that causes compression of our superior and inferior vena cava. Now, I mention those two specifically by name because they're veins. Veins do not have a buildup of pressure in them. Veins are really controlled by gravity and valves. They're check valves so that blood can't go backwards. Our arteries have a buildup of actual blood pressure. That's what we're listening to. That's what we're hearing when we measure systolic and diastolic pressures. If there's a buildup of pressure inside of our thoracic cavity from a tension pneumothorax, our arteries are going to work just fine. But since those veins don't have a buildup of pressure in them, the minute that pressure gets too high and they start to get squeezed, the superior and inferior vena cava will stop and clamp down and shut altogether. The superior and inferior vena cava are the two most important veins in your entire body. They return all the blood back to the right side of the heart. And if blood can't get back to the right side of the heart, which is the side that pumps it to the lungs, where can't the heart pump blood to?
Where it needs to go. If we can't get to the lungs, you can't get to the heart.
The brain.
It
Brain?
can't go, it's going to very quickly stop going to the everywhere. But the initial problem with a tension pneumothorax is the pressure gets so high in the chest that blood can't get back to the heart. That's called preload. If blood can't get back to the heart can't pump it to the lungs can't return it to the heart, and the heart can't pump it out to the body because there's nothing left to pump. The heart doesn't get a chance to refill because all that pressure built up in the thoracic cavity has pinched off those two super important veins.
That's
Now,
how big.
you mentioned a clot. Pulmonary embolism is pretty much the same mechanism. When a patient has a pulmonary embolism, we'll a lot of times abbreviate it as a PE. That means there is a clot in those pulmonary arteries that lead away from the heart, away from the right ventricle, that are trying to go now deliver their carbon dioxide, pick up their oxygen, and send blood round and round. if those pulmonary arteries are blocked and blood can't get out of the heart to the lungs, it can't pick up any oxygen, it can't drop off any carbon dioxide, and the heart is going to continue to pump. So we're not talking cardiogenic shock. The tank is the appropriate size, so we're not talking distributive shock. We have obstructive shock because there's a pulmonary embolism in those pulmonary arteries that lead away to the heart, and we can't have that gas exchange. And if blood's not getting out of the heart, blood's not getting back to the heart, if that's happening, guess what? Blood's not getting pumped out either, and this obstructive process is ruining the whole thing.
Wow.
Now, lastly, we're going to get into metabolic and respiratory. Metabolic and respiratory shock kind of go hand in hand with one another. If for any reason our patient has a difficulty in oxygen getting out of the alveoli, getting off of the red blood cells, or carbon dioxide and oxygen not diffusing appropriately, our patient's going to be in metabolic or respiratory shock. Something as simple as hyperventilation or hypoventilation will actually cause metabolic and respiratory shock because the blood gases inside of our patient just get all messed up. And when that happens, oxygen can't get out, carbon dioxide can't get out, and energy stops being created. The body switches to anaerobic metabolism, even if there's oxygen available. And it's just based on the fact that for one reason or another, the oxygen is stuck in the bloodstream or stuck in the alveoli, and the body goes, we don't know what to do, so we're just going to wreck everything. And that anaerobic metabolism begins, and we wind up in shock.
Wow.
All right, here is where we're going to take a break. Because when we come back, we're going to talk about what the body does, how it does it, and what all that means to us. So let's take a break. When we come back, we'll answer any questions you have at this point, and we'll keep on keeping on.
Okay.
Moving on forward through our shock lecture, we are now going to talk about what all the body does to combat this and how there is a timetable that goes along with all of this. Now, I don't mean time in the actual physical measure of minutes and seconds. I just mean time as in we're on the clock, and the sooner we get to recognizing and addressing what the problem is, the less likely it is that our patient's going to deteriorate to a point where shock becomes irreversible. Because shock has really three stages. Shock is either compensated, decompensated, or irreversible. Irreversible means your patient, even if you get them to where they're going and they're alive, they're not going to survive. They'll die days or weeks later in the intensive care unit. If we can get to a patient soon enough and recognize that they are in compensated shock by identifying what's going on inside them through things like their vital signs and skin color, temperature, and condition, and doing a really good patient assessment, we can steal minutes. And minutes sometimes is all it takes to get somebody to the emergency room and get this problem worked out so that shock doesn't go from compensated to decompensated. Because when we get into the signs and symptoms of shock here in just a couple of minutes, you'll see how much more profound decompensated shock really is, and how much more difficult and how much more action and reaction is going on inside the body Whereas if we had been a few minutes earlier or recognized a few minutes earlier and the patient was still compensating, meaning they were still doing the things that they needed to do physiologically to maintain their status as a live, functional human being, then this patient's outcome may be different, may be better, and it's a whole lot easier for us to fix. That's why I'll say it again. When we treat shock, we want to treat aggressively. So for adequate perfusion, we have to have all of these three things working together. We have to have an adequate pump, an appropriately sized container, and enough fluid to maintain pressure. Because all of this, every last bit of it, is dependent on pressure. When we think back to the lecture in chapter 6, when we talked about systemic pressures, and when we talked about plasma oncotic force and how nutrients and fluid gets exchanged and kept in circulation and pushed out of our circulation so that it's available for all of these cells, all of it is driven by pressure. And all of the problems that will send our patient into shock are going to be also driven by pressure. Because once the pressure starts to fall, whether it's a pump problem, a pipe problem, or a fluid problem, we're not going to have enough pressure to keep the machine running. One of the first things that the body does when it's exposed to something, anything that puts it into a state of hypoperfusion, is it releases all of that epinephrine to stimulate the sympathetic nervous system. That epinephrine goes out and it does a lot. It causes your heart rate to go up. On top of causing your heart rate to go up, it makes your heart beat and squeeze actually stronger to get more blood out. It causes that vascular constriction to shrink down the size of the tank so that it can maintain enough pressure to pump that blood around so that it doesn't just make, waves and splashes in a puddle. That epi is the absolute very first thing that happens in a patient who's exposed to something that's going to cause them to go into shock. So what are some things that you think might jump right out at you if we get to someone who has been in a severe accident and has a bleed or has some anaphylaxis or has any one of the other causes of shock? What are some things that you think you might notice right off the bat?
Bleeding,
Okay.
breathing.
What about their breathing?
It's going to be labored
All
or
right.
non-labored, shallowed, depending on the cause of injury.
So let's not delve too deeply into injury right now, but let's talk rate, rhythm, and quality. Now, you mentioned shallow, you mentioned labored. You think fast or slow?
Slow if we're losing blood.
All right. If it's slow, that means we're late to the party.
Okay.
Because this epinephrine, it excites things, it turns everything up. So their heart rate will go up. You'll see rapid heart rates. You'll see rapid respiratory rates. With all of this vasoconstriction, some of our small blood vessels will actually constrict to the point where they are closed. Your patient will feel cool out at the periphery of their body. So their hands will be cold, their feet will be cold. That's because all of that vasculature has been clamped down by this epinephrine because the body has deemed those structures unimportant at the moment. And they aren't really deserving of oxygenated blood flow, so the body shuts them off. So generally, when we're in compensated shock, we'll see an uptick in their respiratory rate, an uptick in their heart rate. We'll see this vasoconstriction in something like delayed capillary refill or cold hands. There'll be that pale, cool diaphoretic because the body's closing up shop. It's keeping blood central and in all the important organs and closing off everything else. So that's when we see that pale, cool, diaphoretic, or just kind of moist, soggy patient. And this is a result of epinephrine running around inside this patient, clamping down the vascular structure, speeding up the heart rate, speeding up the respiratory rate, all just to make sure that oxygenated blood and perfusion maintains in the places that are important. Because here's what shock looks like. Our early signs, our compensatory stage of shock, is going to be a restless, anxious patient, someone who looks like their body is responding to that fight or flight mechanism, somebody who looks like they may have a whole bunch of epinephrine coursing around in them, trying to decide whether they're going to fight that bear or run away from it. So they'll be maybe even irritable or afraid because that epi is just have them wired for sound. We'll see their heart rate go up because that's what epinephrine does. We'll see their respiratory rate go up because that's what epinephrine does. We may see a slight increase in core body temperature, but the periphery of our patient's going to be pale and cool to the touch because it's not receiving any more perfusion. This is the point where laying your patient flat, making sure they don't have any blood spraying all over the place, oxygenating them and keeping them warm is going to earn our keep. Because let's look at the late stages and decompensated shock. So let's say we were late to the party and we didn't see any of these early compensatory signs. And we show up now and we see a patient who's sort of listless and slow and apathetic. Apathetic means they're past the point of even caring anymore. It doesn't matter to them. And their heart rate is now getting faster. And maybe it's difficult to feel when we check our radial pulse of our patient. And we start to see their blood pressure is beginning to become hypotensive now. What's this whole system run on again?
The whole system is run on
Oxygen.
Even more important than oxygen is pressure. Without any pressure, nothing gets moved. So our blood pressure starts to go down now. But wait a minute, if epi is clamping everything down and trying to maintain a pressure, how come that blood pressure is going down?
because they're compensating for what's going on.
No, they're not compensating anymore. Now
Okay.
we've reached the stage in all of this where the body is actually losing the fight.
They're
When we
losing.
start to see blood pressure begin to fall, the body's not winning the battle anymore. If we were still over here, this is the body mounting all its defenses. It's calling in all its chips, and you know what? It is still in the battle. By the time we get over here and our patient is apathetic and doesn't care anymore, and pulses become difficult to feel, and blood pressure is way low, and your patient now feels cold instead of cool, their body temperature is starting to fall, does it sound like we're still winning the fight?
No.
No, and then now let's look at the rest of these. Patient becomes confused and incoherent, maybe unresponsive or unconscious. Normal reflexes may actually go away. Now our blood pressure begins to reach 0, and our heart rate gets to a point where it can't get any faster, and it starts to slow down. And our respiratory rate does the same thing. It just can't maintain that speed anymore, and it starts to slow down and become irregular. Is this patient getting better?
No.
No, because eventually we wind up down here.
Mm-hmm.
We wind up going from the body was in the fight and winning the battle, to now it can't mount that same response anymore. The body's no longer responding to that epinephrine. It can't produce anymore. It can't do anymore. And we get to the point where things start to slow down. And instead now of being super high, things start working their way back down. If your shock patient begins to have vital signs that are returning to what we would call normal for a second, be on your toes because they're not getting better. Shock needs definitive treatment. It doesn't need, all of the arm care short Band-Aid fixes that we can provide. So if you start to see a patient who, their pulse was just 140 and now it's down to 100, they must be getting better, right?
No.
Their respiratory rate was just 30 and now they're back down to 20. They must be getting better, right?
No, it sounds like but
They're
they're
getting
not.
ready to die. They
Yeah.
are absolutely getting ready to die.
No.
And it's really an important line to draw, the difference between compensation and decompensation. If you think about it like this, right, you see the changes in mental status, right? And remember I said it doesn't have to be this big, profound thing. So let's look here. We had a patient that was just exposed to something. Doesn't matter what it was, but we'll make our argument with the fact that, yes, it was going to cause shock. And when we get there, they're restless, they're anxious, they're irritable, and they're afraid. That sounds pretty normal, doesn't it?
Mm.
And instead of calling 911 when all this stuff first started, they said, we'll get better. And then they didn't. And now they're listless, not hardly even paying attention, maybe falling asleep, apathetic, couldn't care any less, or unresponsive. They've clearly gotten worse, yeah?
Yes.
So all of these problems here on our left-hand side are way easier to fix. And this is where we want to identify shock. This is where we want to begin our treatment for shock. Because the later we are, the more difficult this stuff all becomes to fix. And maybe it becomes unfixable. Because sooner rather than later, if enough cells have died and enough tissues have died and enough organs have been affected and enough organ system has been affected, even if your patient remains alive throughout your entire care and the emergency room keeps them alive, they wind up going into what's called irreversible shock, and they die from multi-organ dysfunction syndrome in the intensive care unit a week or two later. Because all of the insult from this pump problem, this pipe problem, this fluid problem, and all of this anaerobic metabolism and this buildup of waste products and all of the cells dying and all of the tissues dying and all of the organs dying have done too much damage. So realistically, we need to recognize these. We need to see that change in my patient's mental status, that short little bit that makes me think, this patient just got run over by a truck, and I have an increased heart rate and maybe a normal to slightly low blood pressure and some pale, cool, clammy skin and some increased respiratory rate. And, their extremities are really kind of cold to the touch. I don't need to be able to identify where the bleed is. The bleed could be all internal. I may never see a drop of blood on the ground, but it's not inside their vascular structure where it's supposed to be. It's leaking inside of their person, but I'm seeing all of these early stages of shock. I don't have to wait until we get here to say, holy buckets, we probably should get to work and get this patient oxygenated and laid flat and kept warm and transport. Because at the end of the day, this patient needs to be transported to the closest appropriate facility with an ALS intercept en route so that the definitive care and the final treatment can be started as fast as humanly possible before we get to this. Because once the body starts losing the fight, and really starts not responding to all of the compensatory mechanisms anymore, it's a slippery slope, and it happens really fast, where a patient goes from compensation, then, they hang around in that for a little while, but they continue to get worse. And once they hit that late decompensated stage of shock, it's not a very long time before they progress through this into this, and we wind up having a negative outcome. So be aggressive. If you think, act. Now we're
One of
going to
my
talk. Yeah, go ahead.
I was just gonna say one of my questions was, but you answered it when you said ALS and intercepting route. Because I was gonna say, if we pull up and we see all of this, shouldn't we already automatically call for backup, call ALS?
Sure. But remember what I just said right after that was this patient needs transport. All of the fancy ALS stuff in the world isn't going to help this patient. What they need is treatment in an emergency room, maybe a surgeon, but they're going to need, if, let's say it's hypovolemic hemorrhagic shock, right?
Mm-hmm.
Paramedics don't carry blood. They carry saline. Saline doesn't transport oxygen or carbon dioxide. Years and years and years ago, now you always hear me laugh and joke about the things that we used to do that was stupid. Years ago, paramedics would show up to a huge trauma and start IVs that were as big around as drinking straws and force as much saline into a patient as humanly possible, trying to restore a pressure. But was it a blood pressure?
Was it a blood pressure?
Was it a blood pressure? If they were just dumping fluid into this patient, were they restoring an actual blood pressure?
No.
No, it was a water pressure. We were turning this patient into a sprinkler. So we were filling them with something that was doing them absolutely no good and actually doing them a whole lot of bad because, well, we got a pressure back. Whoop-de-doo. Water doesn't carry oxygen anywhere unless you're a fish.
Mm-hmm.
So it's one of those things where now we've come to the point in medicine where we realize that filling this patient full of saline and allowing them to continue to progress through shock and still leak or still have other problems going on the other side of that isn't doing them any service. It's actually causing more negative than it is positive. So transport. If you don't have a paramedic, get that patient scooped up off the ground and get to going. Because they have doctors and nurses and surgeons at the emergency room, they can start blood and we can actually start to getting this problem sorted out. So yeah, would I love to have a paramedic with me every time I left the ranch? Sure, because I know there's things that they can do that I can't. But at the end of the day, I can always load somebody into my ambulance and get to boogieing.
Mm-hmm.
So if you're able, your patient's medical history sometimes will play a very important role in figuring out just how sick they are or how sick you think they might get if they're in shock. There are some medicines out there that people take for things like high blood pressure that actually interfere with the body's ability to compensate. Epinephrine acts on beta receptors to a certain degree. A lot of people
Sure.
will take medications called beta blockers to actually block epinephrine's ability to stimulate those beta receptors. Things like atenolol, anything that ends in OLOL, is a beta blocker. So if your patient or their family tells you as part of their medication list that they take atenolol and they've just been hit by a truck, their body is not going to mount the same response. They are not going to have the same ability to increase their heart rate and increase their respiratory rate and increase their heart's ability to squeeze and clamp down all that vasculature. So their ability to compensate has been effectively removed from them. So trauma patients and medical patients alike, it is very important to get a pretty detailed medical history on our patient as far as, their medication list and their pertinent past history, because there are some things out there that are going to make these patients have a worse outcome. And the sooner we figure out some of that stuff, the better off they're going to be. Our physical assessment, we've already gone over that. Pretty solid, pretty straightforward. We're going to be looking for some of those key signs and symptoms, that change in their mental status, that increased heart rate, that decrease in blood pressure, increased respiratory rate, poor skin color temperature conditions. Remember, generally speaking, pink, warm, and dry is the color we want to see. If you see anything other than that, there's something wrong with the human standing in front of you. They called 911, and the problem is generally going to have something to do with the reason that they are pale, they are cool to the touch, they are sitting in their lounge chair on the deck, sweating like an animal, and haven't moved in an hour. There's no reason, logically speaking, for things like that, right? If I'm just sitting at my kitchen table and I'm cool to the touch, but sweating profusely, doesn't it make sense that there's probably something wrong with me?
Yes.
And we don't even have to be able to identify really 100% what that something is. But you recognize the fact that, yes, there is something wrong. And then we figure out the wheres and what fors from there. Whether it's shock or whether it's one of any of the other multitude of things we're going to talk about, that general impression, that primary assessment is going to tell you a lot. Looking at somebody and being like, wow, they look sick. You want to know why? Because they probably are. And it's really, your assessment can be boiled down to just that. Now, that's not enough. But being able to look at somebody as you walk to the door and go, man, why couldn't somebody else have gotten this call? This guy's sick, is really one of the most important things you'll ever be able to learn to do. And with our shock patients, it's exactly the same. Because like I said, shock is on a very, very narrow, very tight timetable. And if we're already behind when we get there, that means we don't have much time to dally, and we better get going, and we better figure this out, and we better oxygenate, lay them flat, keep them warm, transport. A lot of the other things that we do, especially with a critically ill patient, can be done in our mobile emergency room. That's what an ambulance is. We can do a lot of the things that they can do in the ER. We just have wheels.
That's not basic.
Sure it is.
Oh, okay.
First line treatment for anaphylaxis and anaphylactic shock is epinephrine. Doesn't matter if you're in an ER in Boston or if you're in the back of a Cataldo ambulance in Malden. First line drug is exactly the same. Oxygen and epinephrine. So we already talked about grandma here and some of the medications and some of the changes in age that are going to make her a little bit sicker as far as a shock patient goes. So let's take a look at the other side to that coin. And we'll look at our pediatric patient here on the right side. Kids, generally pretty healthy, right? Their little hearts can beat super, super fast. Their vascular structures all nice and healthy and new. They can clamp down and vasoconstrict and get all that blood circulated to the core where it needs to be, perfuse the heart, perfuse the lungs, perfuse the brain. And they can do that for a good long while. And then what do you think happens?
They lose their battle on whatever it is they're fighting.
They do. And kids lose quick. Kids compensate for a really long time. Their body responds to that epinephrine for a really long time. And then once their reserves have run out, and once that epinephrine stops being able to accomplish that job, kids decompensate in the blink of an eye. Kids go from healthy, looking normally perfused and doing fairly well to not doing anything at all in short order. And that's just the way that it goes. It's like they get to the edge of the cliff and over they go.
Brutus.
Talk about it. All right, folks, that was your shock lecture. Are there any questions out there?
Oh my goodness, so many.
Good.
Plethora. So
That's a
awkward.
It's a lot of information. It's a really big topic, and we come back to it often. Is there at least a general understanding? I don't care if you don't understand the whole thing.
I got a general understanding about it.
Yeah, if we have the important bits, you know, maybe the stuff that I've said over and over and over again, if we can be there and understand the difference between compensated and decompensated, and you know what the treatments are, and I mean treatments in general, not, you know, oh, epinephrine 0.3 milligrams with an EpiPen auto injector intramuscularly in the lateral aspect of the thigh, hold for 5 seconds, massage the area. I'm not looking for that today. What I'm really looking for is just generally feeling okay with the concepts we've talked about, because it's big.
No idea.
No idea. Who's that?
Nathaniel.
We'll get there. Because today we're going to go over it in the lab. We're going to do more medical assessment. We're going to talk about all of this stuff. And I think you probably have a better idea than you think, because you were answering questions. So,
But it's not that I don't. All right, when I say that, it's not that I don't understand it. It's more so that, like, putting it into, I don't want to say real circumstances, because that's still not really justifying the point I'm trying to make. It's really just making it a case by case and actual in real time assumption, and like just having the actual understanding of the knowledge translate to actual. I don't know. Maybe I'm overthinking. All right, I'm
no,
off
I
it.
get where you're going. So actually today, we're going to use some of the case studies to go over the shock lecture in particular. And I think some of that will drive a bit of this point home. And then when we talk about cardiology and we talk about respiratory emergencies and we get a little deeper into the actual bits and pieces of what feeds this shock machine, then I think it'll clear some of it up.
All right, cool.
Just hang in there.
Medical overview.
Medical overview indeed. But we're not jumping right into this. We're going to get into it, but this lecture is, so I try to do this as much as I can. I'm piggybacking something that's easy onto something that I know is difficult. And the take-home message for this is, we make generalizations when we get into somebody's house. There's no way to avoid it. When you walk into somebody's house and you get to the doorway of where they're at, and you see a middle-aged gentleman who is maybe a little thick around the middle, who does have that pale, cool diaphoretic skin, and he's hunched forward at the table, rubbing his chest. What do you think's the matter with him?
I'm gonna think he's having chest pains. He's gonna have complication breathing, and I'm gonna wanna get him.
Don't
As soon
even
as
get into what you're going to want to do just yet. We haven't even spoken to this man. But you're
okay,
absolutely right. That is exactly the way the beginning portion of every single assessment that was ever done in the history of emergency medical services. You get to the door and you look at your patient and you go, all right, middle-aged. He looks like he's been eating bacon and butter sandwiches for the last 25 years. He's probably got hypertension, high cholesterol, type 2 diabetes, and you start running through the list of probables. Haven't opened my mouth once yet. And I look and I see him lean forward, rubbing his chest, and I go, well, I'm probably here for this gentleman's 9th myocardial infarction. And as I get to him, I'm starting to assess his level of consciousness because I've already got my general impression. That's my generalization right there. I'm starting to assess his level of consciousness, his airway, breathing, circulation, and I haven't even still spoken to him. And I say, hi, my name's Tommy. I'm from Cataldo Ambulance. It's nice to meet you. And depending on what my patient says and does next, is going to tell me some information. And it's just a back and forth. It's like playing ping pong. I go, then you go. Then I go, then you go. And that is what this medical overview chapter and lecture is all about. It's going to give you little bits and pieces of how we assess a patient, some things that point us towards what may be wrong with this patient. And at the end of the day, when we finish this lecture, and I'm going to tell you, well, none of this has meant a single blessed thing because the patient don't read the tech book, and elderly people oftentimes don't present the same way younger people do. Sometimes based on gender, patients don't present the same way with the same problems. And it's on us to be that medical detective. That's what this chapter should be titled, Medical Detective Work. Because at the end of the day, if we don't ask the questions and go through our assessment and go through all of the little bits and pieces and pick bits of information out, it's not even that you're going to miss something. It's more on the fact that the patients maybe didn't understand what you were asking, or you didn't understand what they were saying, and the conversation didn't get deep enough into the weeds to figure out that, oh yes, this feels just like my last heart attack. And you go, well, I'll be damned. I guess I was right about the bacon and butter sandwiches. I know I sound like I'm making light, and it sounds like I'm probably trying to make this sound too easy, but this is a game. It
I was
really,
gonna say it doesn't sound easy at all.
oh, believe me, once you get into the flow of actually how this is accomplished, regardless of what your patient says to you, you'll find a way to weed out the important information, whether it's from their medical history and their medication list, or the actual what is going on, the OPQRST and the history of their present illness. You'll get there. You may not find you're at a point where you can actually treat anything or there is anything that you can do about whatever their problem is, but you will be able to put your finger on, for the most part, what system is affected, how it is affected, and is there anything I can do for it? And that's what this is about.
Okay.
So that yawn tells me we're taking another break, though,
I am
because
so sorry.
no,
No, I just don't
I said
feel good,
excuse
so
me earlier
not
because I
that.
yawned into the microphone. What are you kidding? So let's take 10 minutes, get up, stretch, rest your brains for a couple, because this is not heavy lifting.
No chance I rest my brain, because if I rest my brain now, you ain't gonna see me till 3 p.m.
I didn't say nap.
No, that's literally what resting my brain is. Yeah, no, I'm exhausted. As soon as we finish at 4:30, I'm coming home going to sleep.
All right, we're back again and getting ready to start chapter 4. Excuse me. Chapter 14, medical overview. So, generally speaking, patients who need EMS fall into the category of medical trauma or both. When it's both, it's a bit trickier for us because we have to figure out which came first, the chicken or the egg. Did their medical emergency lead to their traumatic event, or did their traumatic event lead to their medical emergency? Trauma is just that. It is some force applied to the body causing some form of injury. Medical emergencies are illnesses and caused by the process of disease. Traumatic emergencies are arguably a whole lot easier to figure out. If somebody gets run over by a truck, we're going to see a lot of their injury. We will see discolorations on their skin. We will see swelling. We will see bones pointed in wrong directions and missing, or, chopped up limbs. That's arguably about as easy gets to figure out. Medical emergencies are a bit more tricky. Figuring out what is going on from a medical standpoint with your patient does require a little bit of that medical detective work I mentioned a few minutes ago. Let's take a look at this patient right here. Somebody out there tell me, what do you think is going on with this guy?
Chest pain. He's
All
holding
right.
his chest.
So I'm going to ask you a follow-up question. Does he look like our typical chest pain patient who we would expect to be having some sort of cardiac event?
No, he
No.
actually looks pretty young.
He looks young. He looks fairly healthy.
Hmm.
So what else could be going on with him?
Maybe an asthma attack. He could be an asthmatic.
Okay, so some sort of respiratory complaint. You just formed your general impression. You see him rubbing at his chest. You think maybe possibly chest pain, but then you went one step further with that and said, well, he doesn't look like somebody who's probably got, a long-standing cardiac history. He doesn't look like my average myocardial infarction patient. He looks more like he could be having some sort of asthma problem, some sort of respiratory emergency. And
He's in shock.
what
His girlfriend.
you just did without even realizing it is, you started working through a list of differentials because you came up with, based on his presentation, based on your general impression, you obviously aren't speaking to the picture that's on your computer screen, probables and improbables, and this is where we start whittling away at what's most likely to be going on with this gentleman. And is it likely to cause him significant problems, significant distress? Or we get into, is he maybe just a little sick as opposed to a lot of sick? Because you mentioned asthma. Asthma is a pretty significant problem when a patient is having a true, real for life asthma attack and having an emergency. And they're going to complain of some pretty specific signs and symptoms as far as our respiratory patients normally go. What do you think some of the things that your respiratory patient might tell you?
Shortness of breath.
Okay, maybe I'm having a little shortness of breath. What else?
It could hurt to breathe.
It's hard to breathe. I'm having difficulty breathing. What are some things you might notice about this patient?
Retractions, nasal flaring, color of skin. They could be cyanotic.
Sweating.
You guys hit all the points. We're going to have a complaint that is in one way, shape, or form in the vein of a respiratory emergency. They're going to complain of shortness of breath, difficulty breathing. I feel like I can't get enough air in. I feel like I can't get enough air out. It feels tight when I try to breathe. We'll see some nasal flaring. We'll see some retractions of those accessory muscles. Maybe we'll see changes in their skin color, temperature, condition. maybe we'll see a chest wall that's barely moving at all. So we know that this patient's not filling up their lungs appropriately and getting all that gas down to the alveoli where it belongs. Do we know one thing about their respiratory status other than it's a problem right now? Do we have any idea what their medical history is? Do we have any idea about anything at this point?
No.
No, but guess what? We're already on the right track to figuring all that out. And that is your general impression 101. You looked at that patient, you said, could be chest pain, might be respiratory. And then we talked a little further and you went, man, it doesn't really strike me as my chest pain patient. Let's start thinking respiratory, and we can always amend that as the situation dictates. Now we're going to look at our next patient. This patient presents in the exact same way, but what do we think his problem is?
But he's grabbing his heart. He has more like a grab. I don't know.
Okay, keep going.
Wouldn't it be
Hey,
that also is like a lot older, so he may have more issue?
A lot older, more likely to have
more
certain issues.
medical. I don't know. I see his veins on his neck kind of distending, and he seems very uncomfortable and like hurtful.
Okay.
Hurt.
Couldn't you make the difference that when people have heart attacks, typically they feel a pain that radiates up the left side of their body? So if someone were to have a heart attack and grab at their chest, that their left arm wouldn't move as much, I guess, compared to someone who's having breathing problems? Or
Well,
is that...
And I'll take that even one step further for you, because I have no argument with any of the things you just said. But naturally speaking, which arm is it easier to clutch at your heart with?
You're right.
Your right arm.
My right arm. So you were spot on with all of that stuff. So what do we think this guy's problem is? What's
Chest
his
pain.
complaint going to be?
Chest pain.
Chest pain.
Chest pain.
Even if it comes along with a little shortness of breath or a little difficulty breathing, his chief complaint, just based on your general impression of what that gentleman looked like, is going to be, before you speak to him, oh, this is probably a cardiac, as opposed to, oh, this is probably a respiratory. And we are still thinking, all right, those two systems are intimately involved. They are absolutely things that feed off of and into one another. We just talked about that during shock, about how the cardiac and respiratory systems are like a peanut butter and jelly sandwich. They're like peas and carrots. So one is going to harm the other one way or another if there's a problem. But we split the hair of, all right, the root problem of this guy's complaint is probably cardiac. Because when we looked at this patient, he's presented in the exact same way, right hand, center of his chest, near his heart. But we decided this guy's problem was most likely respiratory just based on the fact that he was younger. He looks like he's in halfway decent shape, and he doesn't present to us general impression wise as my typical cardiac patient. Now, we could get into interviewing this guy and doing our patient assessment, and he could tell us that he has had 3 heart attacks. He's had awful blood pressure problems since he was a kid, because some of this stuff is based on genetics and some of it is just based on how well you take care of yourself. So there's a little from column A, a little from column B. So you go into everything with no real idea, right? We go into everything clean slate and we cast a wide net. We know respiratory problems and cardiac problems kind of go one with the other. We know a respiratory issue can turn into a cardiac issue. Sure, I'm not even making any bones about that. But if we cast our net wide and start thinking about what are the list of probables, what are the lists of most likelies with our patient, we can start winnowing down what might actually be going on with them. Because the deeper we get into our assessment and the more things we check and the more that we sort of try and get to the bottom of this, Patient tells me, oh, well, my chest hurts. All right, well, how does it hurt? What does it feel like? Does that sound a lot like the quality of your pain, your discomfort? Yeah, it feels really, really tight and like I can't move air good enough. All right, well, you still told me about something about chest pain, no?
Yes.
But does it sound like cardiac chest pain?
No.
No, it sounds like I feel like I can't get enough air moved around. All right, well, you're still talking chest pain, but you're talking a different kind of chest pain. Whereas our patient who is having cardiac related issues and tells me they're having shortness of breath and chest pain, and maybe some of that radiation that was mentioned a few minutes ago about pain on the left side up into the jaw and maybe into the neck and the back, and some nausea and some vomiting. And all right, I'm having some shortness of breath to go along with that. Do you think that's a respiratory issue? Or do we think that's probably a cardiac
I would
issue
say,
causing some respiratory compromise?
yeah. I would say no.
And that really is how we do the back and forth on all of our patient assessments. And as we get into our sample history and we're getting our signs and symptoms, and we're asking them if they have any allergies or if they have any medications or if they have any pertinent past history, we start getting a little bit more evidence for what our general impression was. Because most times your general impression is not way out in left field. Your general impression is that first thought when you see your patient. That's your general impression. And right, wrong, or indifferent, when we're doing our assessment, we're trying to figure out, was my general impression right? Am I on the right track? Am I getting good information that tells me, all right, this is my this patient is having cardiac related chest pain. My protocol treatment for cardiac related chest pain is going to be 4 81 milligram aspirins, chewed and then swallowed. And if they have a prescription for nitroglycerin and they haven't taken any erectile dysfunction meds and they have a systolic blood pressure of over 120, I can assist this patient with one 0.4 milligram nitroglycerin tablet. And then 5 minutes, I'm going to reassess my patient and their blood pressure and their chest pain and see, has it changed? Is the blood pressure still above 120? Can I or can I not give them another of this 0.4 milligram nitroglycerin tablet? And that is just wash, rinse, repeat. That is every assessment I have ever done in my entire life. You walk in and you make that first doorway size up and you think, all right, what is going on with this person? And you ask them, hey, what seems to be the problem today, Bob? And Bob says, oh, I feel like I have an elephant sitting on my chest and I'm having a hard time breathing. All right, well, elephant sitting on the chest tells me one thing, hard time breathing tells me another thing. Then I have to flip a coin as I continue on down through my assessment, and I'm starting now to gather my list. And elephant sitting on my chest tells me he's having a pressure in his chest. All right, can you tell me about all these problems, Bob? How did they start? How did they start? What question did I just ask Bob?
The
Did it-
onset.
Yeah, it was the O in onset. Bob, is anything making this pain better or worse? Does the elephant go away at all? No, it's constant. It feels like I'm being crushed. Okay, so tell me about how this pain feels again. It feels like I'm being squeezed. I'm having this like crushing sensation in the middle of my chest. All right, well, that sounds an awful lot like the quality. Hey, Bob, can you tell me, do you feel this pain anywhere else?
Radiates.
Yeah. What's next?
Severity.
Okay, how would I ask Bob that question?
1 to
On the
10.
scale from 1 to 10 being
Yeah, on a
severe.
scale from 1 to 10, 1 being no pain, no discomfort, because these questions, as much as they sound like I'm always asking about pain, what happens when I get a respiratory patient and they don't have any pain? All they're having is difficulty breathing.
Well, how difficult is it for you to breathe on a scale from 1 to 10, 1 being not that difficult, 10
Perfect.
meaning you're gonna die?
Yeah, on a scale of 1 to 10, 1 being no problem with your breathing whatsoever, 10 being the most trouble breathing you've ever had in your entire life, how bad is this? What's that question telling me?
That question is gonna tell you how bad, how they're, if we're still talking about the breathing, how good their breathing is, or if they're forcing air out, or if it's hard to get air in.
Yeah, that question is going to tell me, first of all, do they have something to compare it to,
Okay.
right? Because if I say 1 being no pain, 1 being most difficulty, 1 being no difficulty, 10 being the most difficulty you personally have ever had, and they say, oh, it's a 10 every time I have an asthma attack, and you watch the light bulb go on, right? Now,
Noted.
the patient has told me that not only do they have something to compare this to, they have something relevant that has happened to them previously. And the past is a very good predictor of the future. What do you think the very next thing I would do would be if my patient told me that? I would whip out my trusty stethoscope and be listening to his lung sounds very, very carefully, trying to decide now, since I have a respiratory patient with a respiratory complaint who also has a respiratory history, does this all fit together?
Mm-hmm.
And it's right then and there where I've finished my sample history, I've done my OPQRST, now I'm getting some vital signs, because those vital signs are going to tell me, do I have any business treating this patient? Should I just transport this patient, reassess them every 3 to 5 minutes? What on earth am I going to do for this patient? And it's all basically conversational.
Now this is all happening on the back of the truck, right?
Not
Alright.
necessarily.
This can happen outside of the truck and as soon as you show up.
Yeah, sometimes a little of both. I mean, sometimes this is happening in my patient's house. Sometimes it's happening on the way to the ambulance. If you walk in the door and somebody looks like death run over, a lot of times we're just snatching them up and we're on our merry way, and a lot of stuff gets done on the way. But am I helping that patient if I just grab them and run screaming from the house?
No.
No, because I can actually provide all the treatment in the house that I can provide in the ambulance. The only thing the ambulance has over that is the fact that it's got wheels and we can move towards the Everett Hospital. So sometimes we have to start treatment in the house. Sometimes we start treatment in the ambulance. It all depends on what my end game is.
Can't you also only give like nitro if they have it themselves? So if you left right away and they didn't have it on them, you obviously can't give it.
Exactly. Then I also lose my ability to do any of the scene work and figuring out what they have for medications, because a patient who's under stress and under duress, they're going to say, yeah, I take lots of meds. Okay, that's not super helpful. Do you know what any of them are? No, my chest hurts. All right, do you know what you have for any medical problems? Yeah, right now my chest is killing me. All right, we are circling the drain here. I'm not getting any good information. If we just go running out of the house like crazy people, we are swinging and missing all over. So there's a fine line between hanging out in somebody's house and asking them pertinent questions and getting good information and wasting time. That brings us to a very good point. Here in class, when we actually do patient assessments and you guys are working your way through and figuring out how this is all supposed to be done, everything is done before we decide we're transporting. So you do your scene size up, your scene safety, BSI, mechanism of injury, number of patients. Then you get to your primary assessment and you start to assess your patient's level of consciousness while forming your general impression. You assess and treat airway problems to make sure that you have a patent airway. You assess and treat breathing problems. So oxygen, 15 liters per minute. We're going to get a rate, rhythm, and quality. We're going to listen to lung sounds. Move down to circulation. I'm going to get rate, rhythm, and quality of my patient's pulse and check their skin color, temperature, and condition. I'm going to make my transport decision. This patient is a high priority transport to the closest appropriate facility with an ALS intercept en route. Now I get to my secondary assessment. And I ask all those OPQRST and sample questions. Hey, Bob, can you tell me how this started? Does anything make it better or worse? Does it move anywhere, or is it right where you're pointing? How bad is it? 1 to 10. How long has it been going on for? That's my OPQRST. I get into the sample and I ask Bob about his signs and symptoms. Do you have any allergies? Do you take any medications? Has anything like this ever happened to you before? Do you have anything in your medical history that would support this problem? Do you have high blood pressure? Do you have type 2 diabetes? Do you have high cholesterol? Do you have a history of asthma? Because now I'm really starting to chip away at what is the root of this problem? Because if I can get down to what is actually the physical cause of this, I might be able to treat it and make my patient better. And I work through the rest of my sample history, the last ins and outs. When was the last time you had anything to eat or drink? When was the last time you used the bathroom? I want to ask that question specifically in the event that my patient winds up on a surgeon's table and an anesthesiologist goes to intubate them. They would very much like to know if Bob had just had like a chilly lunch, because there's possibility that they're going to have some airway compromise when Bob vomits from the passing of that endotracheal tube. So all of this stuff is very, very important to finally getting down to brass tacks and figuring out, am I right? Can I treat? But we still can't medicate this patient because we don't have anything to base that medication off of. We have to get our vital signs, and that will tell us in one big, nicely framed picture. Do I need to treat this patient? Am I allowed to treat this patient? Do the signs and symptoms and the vital signs all match and nicely mesh together for me to make a decision to treat this patient and treat them appropriately? So I would check Bob's vital signs. And if all of his vital signs point me towards, hey, he would benefit from a dose of his nitroglycerin and 4 81 milligram aspirins. Or when I get to the end of my assessment and Bob's telling me he ate a cookie that may have had some peanuts in it, and he's deathly allergic to peanuts, am I seeing anaphylaxis? Or am I seeing bronchospasm related to Bob's asthma? Or is Bob altered? And my last vital sign, I check a blood sugar, and Bob's blood sugar comes back at 42, and he's in the living room barking like a chicken and trying to bite people. Bob, here, why don't you take some of this glucose? I want you to just put it between your cheek and your gums and let it sit there and melt. And 10 minutes later, Bob is all of a sudden now acting like a normal human, conversing with us and moaning and complaining about having to go to the hospital. And that makes me a happy camper because I started my assessment. I figured out what was going on with Bob. And in figuring out what was going on with Bob, I got right down to the point of checking his vital signs and can I treat this? And if I can, I do. And then my reassessment pops up. I've now treated a problem. It wouldn't do me any good to not go back and make sure that this problem isn't either A, getting better, B, getting worse, or C, staying the same. So I say, hey, Bob, after I gave you that glucose, you seem like you're starting to come back around a little bit. Are you feeling any better? Yeah, I took my insulin this morning and then skipped breakfast. All right, Bob, you know, it happens. Or, hey, Bob, did that nitroglycerin make your chest pain any better? Yeah, it's kind of like it's a 6 out of 10 now instead of a 9. All right, well, let's check your blood pressure again, and we will see if we can give you another nitroglycerin to try and make that even a little bit better. And I check Bob's blood pressure, and it's probably still ridiculous. So I follow my standing order protocol, and I give Bob another 0.4 milligram tablet of nitroglycerin sublingually, and we're off and running from there. That is your medical emergencies. That is the way you assess a medical patient. And really, nothing changes but the responses. That's the only thing that changes. You ask the exact same questions, the exact same way, trying to get to the exact same point in your assessment of, do I know what's going on here? Am I able to treat this? Should I treat this? Because if Bob's having chest pain and Bob's blood pressure is 60/40, do I give him a nitro?
60/40? I don't think so. Isn't that too low?
It's way too low. It's half of what it should be.
Yeah.
Your protocol for nitro is 120 systolic. So if Bob's blood pressure is 60/40, you have a treatment for chest pain. But should you medicate Bob?
No.
No,
No.
because Bob will die if you do. Does this lecture make sense?
Yeah.
Yes.
Because this one's a whole lot easier than the last one was. And if you notice, we didn't use a whole bunch of the slide presentation because, well, I don't really need to. What do you have for questions about medical emergencies and assessing a medical patient? Now, again, bear in mind, we still
I have a
have not
question.
done any of the medical lectures. Those are all beginning tomorrow. But what do you have for questions about, like, the process of all this? Because it is every bit as straightforward as I just tried to make it seem. Right now, just start learning the steps. Right now, start learning the words and learning the questions. Because starting tomorrow, I actually will start adding information to that so that, you'll understand that crushing substernal 10 out of 10 chest pain and why nitroglycerin and why aspirin and why vital signs and why all of this goes into properly assessing and treating a patient. So if we can start getting on the same page as far as whittling our way through the steps and making sure we're all marching to the same tune, we're going to be in good shape going forward.